questions. You won't get an opportunity to have so many bright minds here. Many of you just have to put up with me. So today, you have these four wonderful physicians here to go over your questions. So do I have someone who wants to start, or is it going to be like the farthest table? Or there we go. I don't have the right shoes on.
I have a question just to get this thing started. As you know, and Dr. Diamond, thank you very much. I take the Taflinar and the Mechanist, and the program right now is I'll probably be taking that forever, right? Which is fine because I feel great. I'm doing great. Thank you very much to everyone here and you guys up there on stage. I guess my question is right now the programs, I'll be taking that forever. But obviously the hope is someday I won't have to take some drugs and you'll say, hey, Dr. Diamond will say, hey, Barry, you're done. You don't need to do this any longer. Do you think it will be those drugs that do it? Or do you think it's going to be some new drug that's coming that might be the drug that I won't, I'll take and won't have to take any longer? Does that make sense? So do you think of these two, Mechanist and Taflinar, those are the drugs that I'll maybe take for 5 more years and never take again? Or do you think maybe a new drug will come along that maybe I'll take for a little while and that will be the end? I guess Dr. Diamond.
I'll answer that a little differently, which is that the observation has been that for BRAF mutant ECD, if you stop drugs like dabrafenib and trametinib, there's eventual relapse. But those studies, whether it was mine or what Professor Harosh did, they didn't stop in someone who had taken it for 10 years. So we don't know the answer to that. It's a certain period of time, maybe 2, 3, 4 years. So whether the dabrafenib and trametinib will do the deal after 10 years, we'd have to do it all over and see at that time. So I don't think we know. I think we're hoping that something else will come along, but we don't know the answer to whether, people relapse after 2. Is it the same after 5 or 6? We just don't know the answer.
Okay. More questions? Can I stop here?
Okay, my question is, for example, I'm on Zelboraf and have been for 4 years, and my dosage has gone down from 6 per day to 4 per day to now 3 per day. And I've had no active disease for, well, almost a year and a half, but that was a different story. I had switched drugs for a while. How do we know when our doctor can titrate us down to 2 per day? Or there used to be a lot of talk about pulse dosing, and I haven't heard that today.
Perhaps your doctor can see after he examines you, he looks at your clinical images, MRI, PET. Yeah, okay. It's just, and then you can probably keep on tapering to 2 and 1 Zelboraf per day. So it's possible to taper, and it's also possible, in line with what you said, to when you have a non-active disease and that you reach a plateau and you don't improve anymore, and that you do not have side effects of the drugs, you could imagine being off the drug for a couple of months, especially during the summer, and then go back on the drug. And you could imagine this kind of attitude, but it's a case-by-case discussion. Obviously, I don't know precisely your case, but that's how I would probably do in your case.
Do we have other comments on that? Because it's a very important topic here, right? On dosing and decreasing dosing and medication vacations, kind of.
Well, I know that many of us, especially in Italy, are interested in the holiday vacations, and I think this is really interesting to study when you have had at least, I don't know, a couple of months of treatment and that you are really in an inactive state of your disease. And then, and if you have been in this situation for, I don't know, maybe 6 months or 1 year, it would really be important to study the difference between two groups, the group that keep on with the treatment and the group that are off treatment for, I don't know, 3-4 months, to see if this attitude is a good one and if you can reproduce it and then spare some treatment for the patient because you have side effects. And so I don't know if anyone wants to comment on this.
Thank you, Julian. Yeah, I agree with what Eli and Julian has said. I think there's a parallel in other hematologic malignancies. So the first targeted drug that we ever had in hematology oncology is the chronic myelogenous leukemia. So patients who have been in remission for many years, we do certainly give a try in stopping or discontinuing the treatment. However, in the CML or chronic myelogenous leukemia, there is a powerful tool in the blood where you can measure what we call molecular remission. How deep is the remission? I wish we have such a tool here in ECD or histiocytosis. Unlike in pediatrics, in adults, it's hard to find the BRAF mutation in the blood even before therapy. But when, hopefully one day if we have a better technology and we can measure like 1 in 100 million cells or something in the blood or tissue, and we can select patients who have very low level or no level, maybe that's, we can say with certainty that there's a good chance of remission after stopping therapy. But currently, I do the same thing. We do a taper, but we usually keep our patients in remission. We want to see our patients in remission for at least a year or 2 before we attempt such a taper, but not a total stop. Yeah, and then you have to monitor the patients. Yeah.
All right. What I wanted to ask is, if you look at all the research that's being done right now, and if you look at the trajectory, like where do you see our treatment regime 5-10 years out? And I guess related to that, do you think there is a cure at some point in the horizon?
Yeah, thank you. That's a loaded question. So yes, during the last 5-10 years, things have been moving forward. We have identified the molecular alterations, we have targeted them, but there's a question here, like the elephant in the room is, these patients are on this treatment, but when they stop it, the disease comes back. So is it a problem with the target? That means the pills that we take, or have we not identified the actual trigger of the disease? So all these BRAF inhibitors, cobimetinib and MEK inhibitors are tyrosine kinase inhibitors, and they sometimes put the brakes to the disease. And if you get the brakes out, that can come back, So that is why we have seen from some studies in the past that when we take the patients off 100% from this medicine, the disease comes back, and then when the disease relapses back, but when we put them on the same medicine, they respond, suggesting that you can put the brakes again. So answering the cure, I would envision in next 5-10 years, the field will move forward with the new technology, with the gene alterations, with the chimeric antigen receptors, with that type of angle, in addition to attacking the exact molecular pathways to achieve a cure. So the definition of a cure is that based on the NCCN and other institutions or in the FDA, is that the patient should not be on active cancer treatment, and the patient should not have the disease manifestations. for a long period of time. So if you look at the early cladribine or cytarabine studies, there are patients that the curve plateaus after 40%, 35%, and the follow-up is sometimes 5-10 years, the disease has not come back, and the patient is not on active treatment. So is that a cure? Sometimes it might be. So that is why our follow-up is not that adequate to show. So for an example, diffuse large B-cell lymphoma, we can 100% say 60% curable. If I give a patient R-CHOP chemotherapy, 60% curable, no doubt, based on the normal garden variety of diffuse large B-cell lymphoma. But here, because why we have followed this patient for 20, 30 years, and we know that the disease has not come back. But here, with the recent advancements brought up to this level, but we don't have that type of a follow-up to tell you that these patients are cured. So that is one of the limitations. So that's why Dr. Goyal there said, we need research, we need follow-up to answer the question, are we curing the patient? I am not saying right now we are not curing anyone, because Dr. Go here, Dr. Diamond and Dr. Harosh, everyone will have patients that have not been on some treatment and they are fine after 5-10 years, but that is 1 or 2 patients. So that is why it is early for me to say that we haven't cured. And in 5-10 years, I would envision that in addition to these tyrosine kinase inhibitors, we will also see new technology that has come to play in other hematologic malignancies that will join these pathways to achieve you the best benefit and give you the best quality of life.
Great. We have a question over here.
I'm just curious if in your experiences, if blood clots are part of ECD or not. I've had 3, and one was due to a surgery, and one was due to breaking my pelvic bone. That's understandable. But the third one, I have no reason for it. So I'm just curious if there's a connection to ECD or not.
Yep. So I'm a hematologist, so I see blood clots too, but not, in my experience with histiocytosis, ECD included, it's rare to have a patient with a blood clot, and even more rare to attribute the blood clot to ECD. Certainly there are exceptions if there are situations wherein the blood vessels are involved. We call vasculitis. Certainly it's possible that blood clots can form, but I would say that's very rare. And I can check with my colleagues here too.
Yeah, I agree. Unless you have an overt malignancy, which doesn't seem to be the case if you have a JAK2 mutation, or for instance, or if you have another disease, I think it's pretty unusual and unlucky to say.
Yeah, and one other thing is blood clots are much frequent than Erdheim-Chester disease. So if you have a blood clot, I think the best is to make sure that you don't have other secondary etiologies that can cause blood clots. Like there are mutations that is well known in the coagulation cascade that can cause blood clots. In females, there are some other things such as lupus anticoagulants and the things autoimmune related that can cause blood clots. So sometimes it is always blame the cancer type of a thing, but make sure that you address everything like that can give blood clots that is unrelated to Erdheim-Chester or histiocytic malignancies.
Excellent. We have another question over here.
Hello. We're so new to this, but one of our fears is is there a possibility that the medicine therapies, the inhibitors, will stop working? Just like in melanomas, it reduces efficacy over time. And is that a founded fear or something we should be worried about? And if yes, does it underscore the urgency and importance of finding other therapies or a cure to address it?
So the time window that we have from which to answer that question is, I think Julian gave the first patient a BRAF inhibitor in 2011, 2010, 2000. So we have 12 years of data. And unlike in melanoma, the disease finds a way around it, like, 6, 12, 24 months. So we have not really seen that phenomenon of sort of like an escape or a resistance. There's, I think there's one instance in the literature of that. I had a similar case where there was a new mutation that was found, but actually that had been there from the beginning. So that although we only have 12 years, that phenomenon thus far has not really been observed. And that's some sort of a function of whether these diseases are sort of kind of actively sort of mutating and changing so as to cause new mutations. And it doesn't seem to be the observation in the overwhelming majority today.
Especially because due to the fact, one explanation is that the Ki-67 is really low most of the time. It's not like in melanoma. And so the only thing that sometimes you have to do is if you have already tapered your targeted therapy, get from 4 VEM to 1 VEM a day, sometimes you may have to increase the therapeutic pressure and to get back to a high dose of targeted therapies. But for me, the escape in histiocytic disorders like in LCH, ECD, and those histiocytic disorders are really anecdotal, if I can say so.
I agree. I think, in fact, when we see rare situations of patients with the target getting the right drug that targets the target, if we see progression, the first question is, are you taking it? Are you taking the medicine? That's the first question. Are you taking the right dose of medication? Are you missing any of the doses? That's actually the first question. So it's very unusual, extremely unlikely to see resistance.
And one thing, if it comes back, so we have, Dr. Goy and I share some patients that we have seen coming, the disease comes back. So always make sure that we go through the square one, biopsy again, do the sequencing and see whether the disease is the same or it has come to a different aggressive or different type or any other mutations that are there. So always biopsy and see the genetic profile before initiating the next line treatment, if possible.
Okay, we have another question over here.
This is a bit of a segue from what you had said. How many people, anybody, or all of you have seen another cancer with ECD?
Yeah, so that's a good question. So our group, I think the study was led by Dr. Goyal, who has told that patients with histiocytic cancers are much more prone to get leukemias in the blood. That is about 8 to 10 times more compared to the normal patient population. But remember, in the United States, 1 in 8 female will get breast cancer. That is, so in this patient population, if statistics true, someone will get breast cancer. So that is why but if you ask me the question, histiocytic cancers are related to breast cancer, I don't know. But there is a very good probability that these patients will get other cancers which are normal, not normal, which are very frequent in the United States, like the breast, the lungs, and so on. So that is why I always tell my patients, we will treat the histiocytic cancer, and it's a chronic disease, as you always heard, but make sure you go through all the screening that normal healthy individuals will go through by mammogram, the colonoscopies, the pap smears, and because other things, common things are common, and we need to make sure that we evaluate them first and get proper treatment.
Did that answer your question? Yeah, I got one over here first. Sure. Okay. All right.
Well, you're doing fine. It's always been counterintuitive to me, excuse me, that a drug that's been used to treat melanoma for years works with ECD. And is there an easy way to explain that? Because I've never understood that.
So, well, these are the experts here. So, but I will try to answer this. So the drug, forget about melanoma. So the BRAF V600E mutation is what constitutively activates a receptor, which signals the cell to divide. So the cell gets the signal irrespective to any stimulation, constitutively say, hey, divide, divide, divide. If it happens in a melanocyte, it is a melanoma. If it happens in a histiocyte, it is a Erdheim-Chester. So basically like that. So if this mutation happens in the melanocyte divides and spread, and it is causing a melanoma. If this mutation happens in a histiocyte, it spreads, it is an Erdheim-Chester or histiocytic cancer. So I would not frame this as, oh, melanoma, hair cell leukemia, or even in multiple myeloma, 8% of patients will have BRAF V600E. So the mutation is very, very strong. So V600E BRAF gene, V600E mutation constitutively activates it. It happens, it all depends on where the mutation is. If it is a melanocyte, it is a different cancer. If it is a histiocyte, it's a different cancer. Just the cancer name and the manifestations are different.
I think there may be a second part to your question, because I think if I understand it correctly too, is why is histiocyte different than say melanoma or myeloma? And I have to say that histiocyte is distinct from other cancers, because most of the time there's only one, what we call main or driver mutation. But for melanoma has tons of mutations beyond BRAF. BRAF is common to most melanoma, but they have like 50 other different mutations. And so they develop resistance because the other mutations may drive the resistance or overcome the BRAF drug. And the same thing for colon myeloma, they have more than one mutation, not single mutation.
All right, excellent questions. We have one over here.
Just wondering your thoughts about scans that look much improved, but symptoms are not.
That's Dr. Goyal's question. There.
Are you talking about neurologic symptoms in particular, or? Yeah, so I mean, I think that sort of like I mentioned earlier, I think that it's unclear whether some of it is just the footprint of damage done from the disease and therefore may not improve even with the best possible brain penetrating treatment, or that to some extent, and with just the fact that some of these drugs don't enter the brain particularly well. And, the MRI is just a limited tool. The MRI can only show so much, and it doesn't always show the scarring or the microscopic disease. It's an imperfect test. So I would say that many of us have experience with varying degrees of neurologic improvement, although usually the scan improvement is greater than the functional improvement. Ideally they're one-to-one, but not always.
And there we go.
I think earlier in one of the presentations, they were talking about how you can improve somebody's quality of life by helping with fatigue and problems with controlling pain. And I was just wondering if you had any further thoughts about that. I mean, it'd be great, being on the horizon for something to be cured. But on the other hand, if the experience of it is such that maybe the way it impacts your life might be half of what it was before. Didn't know if there were any other comments about that. I know Kevin talked some about that and some of the cycle that occurs, but things you can do that can help with those two driving factors in terms of, person's quality of life?
Who wants to tackle that one?
But also, I mean, so, fatigue is like the albatross, it's like the very, very difficult symptom for people. And there's probably any number of causes, the disease, the treatment itself, and then, a bunch of other things that you need to look into, whether it's thyroid or sleep or, exercise. And, I just try to encourage people to address them, as many as possible. I mean, exercise is very hard to do, especially when you have limited mobility. So it's trying to, as many of those as can be addressed, because even if your energy can go from like a B- to a B, that's not great, but that's an improvement that could be meaningful to some people. And then the whole sort of galaxy of things that Kevin talked about, whether it's, the mindfulness, the sort of holistic approach, I think is another thing that should be pursued in parallel. And I think that a lot of these approaches, they sit in blind spots to us. We have our own sort of things that we try to intervene on, and there's a whole other sort of things and tools in the catalog. So I think it's helpful for us to hear the other things that people do.
Yeah, I fully agree with Eli, and there are other diseases much more frequent than ECD. One of them is systemic lupus, and systemic lupus, you have patients who, even when they have a calm disease with no flares, who say they have fatigue pain. And so I think it's very important as a clinician, we are focused on, trying to find the best treatment and like to taper the targeted therapy to stop vacation, etc., etc. But I think in parallel, most of the patients who express some fatigue and pain should do exactly what was explained this morning and try to find another approach, which can be associated to the treatment with pills and stuff like that. And I think there is very often not a parallelism between the activity of the disease. In this case, we're speaking about ECD, but it's true with other much more frequent diseases. And I think it's important to address this problem along with the treatment or independently of the treatment, and to have other health specialists apart from a physician to take care of that.
Yeah, I agree. I think I heard the phrase blind spots, and I have many blind spots myself. And so as clinicians, say hematologists or neurologists, I think we focus on the therapeutic side. Is the tumor shrinking? Is the PET scan improving? Certainly we care about the quality of life. And sometimes what I try to do is maybe have another member of our team or someone not from our team have us see the patient. Let's say I have Dr. Abekun here see my patient, or my nurse practitioner, or referral to palliative care, integrative medicine group. And other providers may see this patient with a fresh set of eyes and find potentially treatable conditions that may contribute to fatigue or cognitive issues and so forth. Because when you see a patient every month, we're gonna develop some blind spots. Yeah, so that's my way of kind of making me see my own blind spots. Yeah.
Yeah, that's great, because we're treating the person, right? We're not just treating the mutation here. Who's got a question on this table? Someone's burning with a question, right?
I have a question about neurodegeneration. I know it might look different in everyone, and I know the most common is probably balance and speech, but have you seen anything else? Any other symptom?
For neurodegeneration, Yeah, I think you have some swallowing issues sometimes, but apart from the two you mentioned, but I'm sure Eli could add a couple of symptoms.
Are you saying without speech imbalance problems or in addition to? You're
In
saying
addition to.
in addition to, yeah. So I mean that part of the brain regulates, not just movement, of the coordinating your tongue and but can have some relationship to mood. So there is what's called cerebellar affect, when people have mood disruption. I would say that these things are not usually far out of proportion to the mobility. They may be proportionate. So things related to mood instability, and then occasionally thought disturbances, like sort of paranoia, like kind of things in that category. In ECD in particular, I find that those types of issues are kind of in step with the mobility problems, which is different from the neurodegeneration sort of associated with Langerhans, which is a different thing. But those adolescents, they often have had a psychiatric disturbance years before the mobility things ever set in. But I think for ECD, they tend to kind of go together, not perfectly, but to an extent.
All right, I think we have a question over here.
Hi, and thank you for being up here and answering these questions. Very helpful. Specific about DI. One of the challenges I've been wrestling with recently has been not being able to sleep through the night and waking up multiple times, and also balancing the number of or the dosage of DDAVP relative to my sodium levels, which can go low. So in the balancing of how frequently and dosage of my DDAVP, I end up not being able to sleep for any consistent amount of real deep sleep. I think that adds to my issues, and just trying to figure out, is there potential solution, or is it really for my endocrinologist to kind of figure out what the balancing act is? But I think from a lifestyle standpoint, if I could figure out a way to sleep through the night, it would really help me. I don't know if that's a specific enough a question, but if anyone can add
No,
to it.
it's a tough one, because you want to have relief of the symptom, but overshooting by having the sodium go down is more dangerous clinically, right? So we easily tell people to just err on the side of peeing too much, which is like easy for me to say because I'm not up all night, So you can play with the dose with the help of your endocrinologist, and then sometimes actually the route of administration, some people find the nasal to be more long lasting than the pill. So there are different formulations that you can kind of play around with, but those competing interests of the sodium and the frequency is very challenging. So
You want to comment on how often treatment of the underlying ECD results in people in remission from the DI? And
I don't know so the dogma used to be that DI never improves, and then I think we all started seeing with targeted therapies that it actually can improve to varying degrees. However, also the medicines can cause lowering of sodium, and people can run into problems, when those sort of curves are not intersecting. So the kind of always have to be adapting the dose, and the improvement can even happen after some time. So it's a challenge.
And we don't have a endocrinologist here today, but most of our teams, we usually make sure the patient also has an endocrinologist, because us hematologists or neurologists only know so much, and the endocrinologists come into handy there. You had a question?
I was wondering, and I'm coming from having worked in aging and caregiving and Alzheimer's and those types of, chronic diseases. But as I'm listening in on the community, you sort of get this, how do I know that this is ECD and, whatever issue I'm having, and it's not some co-occurring chronic disease. So, like regular diabetes or, chronic heart failure or osteoarthritis or these conditions that become more prevalent as you age. Like, how do I know my bone pain is osteoarthritis versus ECD?
I think the patient is always right over the doctor. So, I mean, if you have the experience of your disease, and so if you, at one point, if you find that you have a weird pain, a bizarre pain, or a symptom that is not, it's a new symptom that you had not experienced before, you should ask your physician and not attribute by excess any symptoms or any new finding to ECD. I don't know if I'm clear. I mean, you should, it's like the clots or some of the symptoms and the questions you have been asking. And I mean, it's probably more difficult for us to try to say this can be attributed to, or I mean, it's important that you tell us everything, and then we try to figure out if it's attributable to or if it's something else. Because obviously, if you are 65, 70, a male, that you have been smoking, whatever, you can have another, I don't know, you have a cancer due to tobacco, and it's not lung involvement due to ECD, and so on. That I can give you like tens of examples like that.
I'll just add that this is, Grace, this is why I need my ECD patients to have a good primary care doctor and not to check out because the patient has like a rare cancer and now they have an oncologist. I think that's like exactly the wrong mentality, because things happen to everyone that are not ECD. And so I always need my patients to have not only a PCP, but a good one, you know.
Eli, maybe I asked you a little bit late here, but could you move your chair a little bit forward?
Say it again?
Can you move your chair a little
Sure.
bit forward so you don't fall off? There we go. We have a question over here.
Hi, my question is just how, well, first of all, thank you guys, everyone, for all that you do to help everyone with the ECD, but I'm also just curious, how often do you collaborate? How often do you get together, or how often do you share stories and find similarities, and maybe what's working with one set of doctors, or how often is that happening? I'm just curious.
Not enough, but we do try. You want to talk to Ron about your tumor board?
Yeah. Oh, okay. Yeah, I think with respect to my colleagues here, and again, as Jisma said, I think Dr. Diamond and Dr. Harosh, they're experts, I guess, before I was born. And I've been reading their papers. Kind of my first ECD patient, I have to read Dr. Harosh and Dr. Diamond's paper. That's how far ahead they are, from me, or were at least. So yes, we do communicate and collaborate. We meet more than just ECD GA meeting. There's other ECD Histocyte Society meeting, American Society of Hematology. In a different capacity, Dr. Diamond and and Dr. Goyal and others have, we meet almost, I think I see him too frequently. Let me put it that way. Dr. Diamond in the Zoom, and Dr.
I'm
Goyal.
older than you are, and you see me
Yeah.
too frequently.
Yeah,
we're doing well. Yeah.
Yeah, okay. I think I have dementia now. Dr. Goyal, I want to say I trained him, but I think he's training me now. We meet every week, actually. Still going through the mentorship mentee relationship. Yeah, and I don't really know who's the mentor or the mentee anymore. And then the other side of the story is, as Paul was trying to suggest, is It is important, not just for us here on the stage or here today. It's important to share our experience to other physicians, non-physicians even, how to diagnose ECD, histiocytosis, how to identify them. That's the biggest challenge. And so 7 years ago, we put together this histiocytosis working group at the Mayo Clinic, and we assembled about a dozen doctors, cardiology, pulmonary, radiology, pathology, rheumatology, and even more basic people in research, informatics. And we have a tumor board every month, 3 to 4 cases every month. And so it's a rare disease. So one case is now reviewed by 12 people. And those 12 people will teach their own departments or divisions. And so that's a multiplier effect. So we found that to be very helpful educationally. One patient teaches more than 12, maybe more than 35 doctors at a time almost. And also the tumor board, you know, we're trying to work with, I think ECDGA and Society. Perhaps these tumor boards can also be expanded in some capacity to allow other institutions to join in, especially for difficult cases. And so I think that those are the efforts that we're trying to do and disseminate.
Yeah, I won't take long, but this is important for Grace's question before as well. So the multidisciplinary approach is very important, but most important, I believe, is so we have neurologists, hematologists here, but these are specialized doctors. But so early patient at the new upfront diagnosis, they will present with a rash, a bone pain, or something very commonly seen, and that these patients will not go to a hematologist first. These patients will go to their primary care first. So if the primary care physician doesn't have the Erdheim-Chester disease in their differential diagnosis, these patients will never get diagnosed. So most importantly, I believe, is that we need to, of course, it's a very rare disease. So when you reach out to American College of Physicians, they will say like, look, we don't care because it is, there are more important things than rare Erdheim-Chester disease. They might, I don't know. But that is not the right way. I think we need to educate our primary care, the forefront physicians, to get this under the differential. If you see a rash like this, if you see like a white rim, like the centralism in the eye, if you see a bone pain, and if you see a hairy kidney in the CT scan, make sure that refer those patients to hematologist or appropriate physician, so that these patients can be diagnosed early and get treated and give them the best quality of life that they deserve. So that's why we spoke with Kathy as well. We need to educate, we need to collaborate not only with the specialists, but also with the primary care field as well.
So that was a great question, just reminding us, as doctors, we need to talk to each other more. But these 4 up here are very approachable. I mean, I don't know, Eli, how many emails do you get a week on questions about managing ECD?
A lot.
Ballpark.
Yeah, I'm not, a lot. Yeah.
All right, we have another question over here.
So we've talked a lot, and some of us have experienced the length of time it takes to get a diagnosis. My question is about what we know about the pace of the progression of the disease, and whether there's good education on that, or is it largely wisdom and lived experience of the doctors who are helping to take care of us?
I think I think nobody really knows, like when you're diagnosed with a disease, you can have only, you know, a little bone pain and high CRP, and that's all, and nothing else will happen. And in the contrary, you can have a much more multi-system disease with CNS, heart, etc. And I think it's impossible upfront at baseline to know exactly what is going to happen. There are multiple natural history of diseases, and so it's a case by case I would say, discussion. But what we know is that some patients having certain mutations will have, for instance, no CNS neurodegeneration, or will have a worse, maybe a certain phenotype and certain worse prognosis than another. But I think it's impossible in the beginning to know, I'm sorry, to know exactly what would be the history of the patient. But in my experience, I would say that at a time zero, when you meet a new patient, usually the phenotype he has, I mean, in a year from now, he's not going to have 3 more organs or system affected. Usually, the picture in the beginning is the picture he will have in his history. So you're going to treat him or her, and you're not going to 2 years after have 3 or more system affected. That's a little bit maybe a reductor for the disease, but it's the picture you have in the beginning is more or less the one you're gonna have.
Okay, I think we have another question back here.
Hi, I actually had 2 questions. One of them's kind of quick. Is there such a thing as a sodium test, a home sodium test, or have anybody heard about a home sodium test coming up in the future? Kind of like a glucose test that the diabetes people do?
No, I don't know. I haven't heard. But the problem with the home sodium test would be like, if it is low glucose, you take glucose.
Right.
If it is high glucose, you take insulin. But if it is low sodium, there are multiple ways that you can treat a low sodium, and the etiology might be either take fluid or restrict fluid.
Oh.
So you need to go to a doctor to make sure what is the best approach to treat the sodium. So I don't think home sodium is a good idea. Like, if it's not a good business, so I would not do it.
Darn. Okay. The second question I had is, it seemed like when I think it was Dr. Diamond did his presentation, he said one of the symptoms that came up was heat flushes and hot flashes. And it's the first time that I've actually seen it as a symptom on one of the charts. And maybe it's just because I haven't been paying enough attention, but how often does that come up? I mean, I've got terrible ones. So I'm just wondering, do you see that often? Is that in a lot of the patients that you have with ECD, regardless? And do you think it's a symptom of going through chemotherapy, or is it actually something that's going to continue on when you have ECD?
I usually see that as a symptom of untreated disease, whether it's Langerhans or Rosai-Dorfman or ECD. Usually, I think of it as sort of hyperinflammation in the body, and it usually improves with treatment. And if it's completely unabated by the treatment, then I sort of wonder whether it's other causes.
All right. Where else do we have questions?
Just a follow up on the hot thing, heat or hot flashes. I think the only other thing I could think of is like hormonal problems. And so most if not all of our patients, we have our endocrinologists make an evaluation to see if there's any certain hormone deficits besides the diabetes insipidus. So sometimes they may experience that too. Yeah.
Do we have another question over here? Or do I have to ask people? Paul, I'm going to ask you. I know you're the quiet type, but you have a bunch of questions.
But they've been pretty well answered.
Oh, thanks.
So I guess the one I would have is, when treatment is reduced or put on a holiday, how fast can it come back? Can the disease start presenting again?
The answer is it is widely variable. In the cobimetinib trial, people stopped systematically. So I know that in that context, some relapse happened as early as 4 weeks. And then in the other study that I did looking at this, it was as late as 3-4 years. So it's entirely variable.
Yep, probably if you have, if you stop after many years of treatment, chances are that it will not start again like 4 weeks after. I mean, in the trial we did like 7-8 years ago, patients had been treated, I think like 6 months to a year, and at least not 3 or 4 years. So, and we had some relapses quite fast in some of the patients after a couple of weeks. And so I imagine that if you are in a situation of calm disease, then if you stop, if you go from 1 Zelboraf per day to 0, I'm pretty sure that the disease will not flare within 4 or 5 weeks. It might usually be longer, but I cannot exactly give you a time frame. But it can be many months or many years, I would say.
So it's very important to be followed by your doctor if you do decide to stop, because it can be variable. What about when someone is on treatment and they stop and the disease comes back, but they had been responding to the treatment before? Do they generally respond to the treatment again?
Yeah, if you re-challenge, in most of the case, it works. That's the good news about it. Yeah.
Okay, just 2 things. Number one is, what is the youngest generally, like speaking, is it like, I guess from everyone's different experiences, is this something that's found usually in younger people? Is it just usually older? My husband's is 36, so I'm
That's
like
pretty.
a little.
That's pretty young. No, but you can find ECD in patients who are a couple of months of life. It's pretty rare, but you have kids with ECD, 25, 30, 40 observations, probably with less than 15 or 18 years old. But this is rare, and it's usually after I would say 40, 50 or 60 years old. I mean, but it's not unusual. It's not atypical to have ECD when you are into your 30s, and usually you have more men than women. You have you have 75% of men and 25% of women. So it's I mean, it's not if you have a diagnosis with ECD at 36, it's possible.
Wow.
I mean, it's not.
Okay, and the second thing, we were talking before about the different types of doctors that should know about it, because it can come from a different area. And I just want to say that from my experience, it was 9 months. My husband was coughing and also was vomiting and could not eat. So gastroenterology, no one knew anything. I mean, no one knew anything anyways, but I feel like just to add here that gastroenterology, I think is very important for them to know about ECD.
Yeah, that's true. I mean, if I think about the gastroenterology and hepatology, which often comes together in France, it's probably one of the areas where we have to educate this specialty. But it's true that the involvement of the gut and is really rare in ECD. But there are some hepatologic aspect of the disease who can be found as well in LCH and ECD, called sclerosing cholangitis, which are hopefully very rare in ECD, but it needs to be well known because it can be quite severe. So.
All right. I think that's the end of our session. All right. Thank you. A round of applause for this panel.